Good morning, participants. Good morning, sir, and welcome to India, although virtually. Before we start the webinar, please keep yourselves muted. We are going to start the webinar now. Mental health at large influences our quality of life and hence needs to be taken care of and maintained. One way is through connection, that is, being in a community, which is not just an unity, it's a feeling. Community is critical for us to thrive, especially for someone with mental illness who is experiencing the common symptoms of loneliness and isolation. It provides us with a feeling of belongingness, support, and a sense of purpose. Today, we will get to know about the treatment and care system within community mental health services from our expert. Before we begin the session, I would request Professor Rita Basu from Department of Applied Psychology, University of Calcutta, to welcome the audience and welcome Sir as well. Rita ma'am, over to you.
Thank you, Shahili. Am I audible?
Yes, ma'am, you are.
Thank you, Shahili. Good morning to all of you. On behalf of the Department of Applied Psychology, University of Calcutta, my heartiest welcome to our today's speaker, Dr. Saumitra SenGupta. Starting his journey in physical science with honors in physics from the then Presidency College of University of Calcutta, Dr. SenGupta's aspiration intermingled with the behavioral and social science. And now he is senior consultant and special advisor
There is a connection problem. I think Rita ma'am is not audible. I would request Nanika to go on introducing Sir.
Yes, ma'am, definitely. Good morning, everyone, and good morning, sir. You are welcome to India, though virtually. And welcome everyone to Zoom webinars once again. So today's speaker, Dr. Saumitra SenGupta, recently retired as the Executive Director of the California External Quality Review Organization, CalECRO, and now serves as a Senior Consultant and Special Advisor. Dr. SenGupta has worked in mental health service research in California and nationally for over 25 years. His doctoral dissertation was supported by a National Institute of Mental Health (NIMH) grant that examined the effectiveness of supported employment models for the seriously mentally ill in the early days of supported employment and clubhouse movement. He has served in the number of capacities, including on the faculty of the University of Arizona Medical School and as a research psychologist in San Francisco Mental Health. Dr. SenGupta is an expert in quantitative and qualitative research methods and utilizing information systems data for mental health service research. He has served as the principal investigator of several federally funded mental health initiatives, as well as on NIMH and SAMHSA review panels. Dr. SenGupta has also served as an elected board member of the American Evaluation Association, AEA, and was the founding chair of the San Francisco Bay Area Evaluators, SFBAE. His publications include 2 co-edited volumes of Cultural Competence and Feminist Issues in Evaluation Research. As we move on to begin today's webinar, please keep your audio muted at all times except when prompted. You may have a number of questions throughout the length of the webinar. We request you to post them on the chat box and we shall communicate it to the speaker during the last 30 minutes of the webinar. You will be provided with the link to a feedback form at the end of the webinar. Please stay with us till then so we can send your certificates directly to the email address, which will be collected through the form. Please provide your name on the feedback form as you would like them on your certificate. You will receive the certificates on the span of next 7 to 14 days. Hope you all have a great time. Thank you again. And I would request Saumitra sir to take over from here. Thank you, sir.
Okay, thank you, Nanika, and thank you, Shaili, and thank you, Shubrata, and thank you, Rita. I know you had a little technical difficulties. I hope you can all hear me very clearly.
Yes, sir.
Yes, sir.
Okay, great. Thank you. And it's really an honor to be invited back to my alma mater. As Rita started talking about, I went there for a year, and then various different things came up in life, and I ended up in the United States, something I never actually thought I'll be doing. But I've been here for the last 33 or 34 years, and I've seen a lot of change in the topic that we are going to talk about today, community mental health care. In the last 35 years, there's been so many changes, and I'm really pleased to talk about it. A little bit more about, not so much about my background, which Nanika read out really nicely, just a little bit about where I come from, really. Very important to mention that, just to provide a little bit of context before we move on to the next slides, is really mental illness is a very strange, interesting, sad, sometimes happy illness. It's a very interesting thing. A lot of us have family members. A lot of us ourselves may have had some kind of mental health issues in past life. And what we know is that this is one of the, for lack of a better word, one of the diseases that is really not taken as a disease. Mental illness comes with a lot of stigma. So I really come from, despite all my other professional background, I really come from a very strong advocacy background. I like to advocate for the mentally ill. I like to mix with individuals who have mental illness. They're my friends, they're my family members, and they're everybody. They're all around, and I spent a lot of time with them, both professionally and personally in my life. And to be honest, I know on this call, this particular webinar, so many of the presenters, you're probably professionals in the field, you are therapists, you are counselors, you are caregivers. And I have to say that I have learned a lot in my life from individuals with mental illness. I just want to acknowledge that, because oftentimes we come from an attitude or a position that we are somehow the experts and we know a lot about mental illness. But I will say this, those who have had lived experience in life, they know what it is like a lot more than many of us who haven't lived through that experience. So that's just a little bit of context I just want to mention before going into the actual subject. This topic, community mental health care, this is obviously a very extensive topic, if not particularly complex. It's a very wide topic. So I will be actually kind of dividing into a few bite-sized things. And, in terms of my presentation, any presentation I normally make, this is a very weird time, as we know, with pandemic and COVID-19 kind of restrictions. It's a very weird times. I like presentations where people just suddenly raise their hands and start talking, and unfortunately that's not going to happen. So I will take, the plan is it's hour and a half presentation, and we're about 10 minutes into it. So what we'll do is in about 25 minutes, I'll take a short break and try to address, if you have questions or comments, some of those, not all of those, and then try to save about half hour to 25 minutes perhaps at the end so we can get into some of the more question answer in a virtual setting. So that's kind of going to be the structure of today's presentation. I wish I was with you in person in an auditorium or in a seminar room or somewhere where you could just interrupt me and ask a question. Unfortunately, that's not the format and it wouldn't work. And as the folks Nanika and Shoili introducing me mentioned, please keep yourself on mute if you can. I know we are all working from home. A lot of us are working from home. So there's life interferes with our best plans. I understand that, but keeping yourself mute is probably the best way to prevent it. So with that, let me get to the basic outline of this presentation, what we'll be talking about. So first of all, I just want to kind of introduce mental illness a little bit and what kind of burden that poses for individuals who suffer from mental illness. Then we'll get into what is community mental health. And unfortunately, in this slide, I have a typo because initially I started organizing a little differently. That's not a part 2, it's really part 3. How do we ensure quality? By the way, at the end of this session, I will be sharing the PowerPoint with Shoili, and hopefully you will have access to that PowerPoint in some fashion. It's a short PowerPoint. It's not a very long PowerPoint. As I said, I really like to talk and discuss and answer questions. That's the best way to learn, just giving a very didactic lecture and having a lot of bullets, although I have quite a few bullets. That is often not very conducive to learning for a lot of folks. So I like to discuss things. So these are the 3 areas: burden of mental illness, what is community mental health, and how do we ensure quality, specifically in the context of community mental health. And along the way, I'll probably share some of my experience, even though they might not be in the bullet. So you have to bear with me. I'll bore with my probably personal or professional life from time to time. Okay. The focus is going to be really on the seriously mentally ill population, often also referred to as seriously and persistently mentally ill, or SPMI population. We'll be using the term SMI all the way. We're not going to use the SPMI term, but I will be explaining why sometimes it is SPMI, not SMI. And then what really distinguishes serious mental illness from so-called mild to moderate, or M to M population? How do we care for these individuals? What are the best ways? And how do we really ensure the quality of care? This will be the focus of this presentation. And I want to acknowledge that obviously you have either you're a psychology professional in some areas of psychology, and you probably, or else you are really interested in psychology. That's why you have joined this webinar today. Even if you may not have any formal training in psychology, that's okay. This particular presentation really, in many ways, does not require formal training. A lot of you might understand it if there are folks who have lived experience, you will relate to what I'm going to talk about today. So that's kind of the level of this. And I realize many of you are really specialized in certain aspects of psychology. Obviously, psychology is a vast field. It's got so many different types of specialties, specializations, and you might, for instance, be a marriage and family counselor. That's fine, but sometimes you might encounter this, or you have an interest in this area. But I do understand that my presentation is going to be a very narrowly focused presentation on the seriously mentally ill individuals. Okay, so before we can talk about mental illness, it's really important that we come from a strength-based perspective. What is mental health? Mental illness is in a way, easier thing to define than mental health. Mental health is really a more abstract concept. But without understanding what mental health is, we really cannot understand what makes one ill. What is lacking in someone's life that makes that person mentally ill? It doesn't mean that person lacks mental health. It may mean that person really lacks certain aspects of what we consider mental health. And obviously, those of you who speak Bengali or are Bengali, I mean, there's a famous Bengali saying, Jato Muni Tato Path, which essentially means however many sages are out there, that many ways are there to really reach your destination or destiny. Likewise, for mental illness and mental health, there are many, many philosophical, theoretical, and practical ways that one understands mental health or mental illness. American Psychiatric Association defines mental health as that involves effective functioning in daily activities that result in productive activities such as going to work, school, or caregiving, having healthy relationships, and also very important that you have the ability to adapt to change and cope with adversity. Very, very important aspects of our regular life, and we often do not even pause to think. Those of us who might consider ourselves, quote unquote, normal, we often make changes, make adjustments in life. Let's just say, I mentioned the thing, marriage and family counseling. Those who practice that kind of psychology, you know very well that one of the things you are trying to impart to couples in couples therapy sessions is really, how do you adapt to change? Or how do you adapt to various types of different situations where you do not agree with your partner? For a lot of people, that comes more naturally. Lucky them. But for a lot of folks, that doesn't come very naturally. And for some folks, that can present really insurmountable type of barriers. So the third bullet of ability to adapt to change and cope with adversity at work, in relationships, in your personal life, social activities. We are often faced with adversity and we deal with it without even stopping to think about it. That's because perhaps we don't have a mental illness. We are mentally healthy. So these are kind of indicators that you have good mental health. Now, what happens if you don't? That's the same organization, American Psychiatric Association, also defines what is mental illness. So collectively, that refers to all kinds of diagnosable mental disorders or health conditions that affect that creates significant changes in thinking, emotion, and our behavior, distress and our problems functioning in social, work, or family activities. We all know we don't often all get along well within our families. That may or may not be always mental illness. How we cope with it, or how we may not cope with it, are unable to cope with it, that may be problematic. That's when mental illness might manifest itself. Very important thing, all of you know it, but I'll have to say it as an advocate again, that mental illness really does not discriminate. It can happen to anyone. It can happen to rich people, it can happen to poor people, it can happen to men, it can happen to women. It can happen to someone from Gujarat, someone from West Bengal, someone from Kerala. It doesn't discriminate based on your origin, based on your demographics, based on your socioeconomic status. It happens to all of us. As I start talking about these things, and you look at this definition of mental illness, I want you to think of individuals that you may have encountered either in professional life or personal life, who you might look at these bullets and say, well, that individuals are so and so kind of fulfills this broad basic criteria of mental illness. Mental illness can really take various shapes and forms. This is one of the challenges of psychology. I think from even basic Freudian or pre-Freudian psychologists, like Kraft-Ebing or other folks, you know, from that time onward, and even today's world, we still often, despite all these nice definitions, we often struggle to really describe what mental illness is. A very good example, I mean, I hate to get into diagnosis-specific conversation, but, you know, one particular diagnosis, borderline personality disorder. It's a very complex disorder, actually. Fortunately, now we have very good evidence-based treatment, but the individuals, a lot of your friends or relatives might have, or we ourselves might have borderline personality disorder. It's very hard to often tell. We often call these people difficult people. So mental illness really can take various different shapes and forms. It's very hard to tell who is mentally ill. It's often a matter of perspective. It's often a matter of your professional knowledge. More than the knowledge, really your experience working with these individuals, that at some point you're able to really diagnose, or you're really able to distinguish between this, again, quote unquote, normal state versus mentally ill state. Very important to recognize that most of us have certain, perhaps, phobias or certain manias, you know, or certain other traits or certain other odd habits. But sometimes they're not severe enough that it really interferes with your ability to maintain an otherwise normal life. So for most normal people, you will be normal in that kind of situation, despite having certain functional or behavioral impairment, but because you may have very good education, you may have a good job, you might be the best father or mother to your child, or you might be the best husband or wife. So people will overlook those kind of little shortcomings in that kind of a situation. But we probably all know some people who have these kind of issues that may be interfering with some aspect of life from time to time, such as going to a movie. If you have tremendous claustrophobia, I mean, going to a movie might be a very bad experience for you. You may not want to go. But that may not necessarily mean that you have certain kind of mental illness. It may just be your functioning is impaired in one particular situation because of your phobia. So there's a broad range, various shapes and forms, and a broad range. And National Institute of Mental Health in the States, they have coined a term called any mental illness, AMI, to denote all mental illnesses. And what my topic is, community mental health care, that really relates to this particular area, serious mental illness, or SMI. I will say that I kind of refer to SMI for both the actual noun, serious mental illness, as well as for individuals with serious mental illness. I will refer to them as SMI individuals. But SMI is probably not just a subset, it's probably a relatively small subset of AMI. And this is really reserved for very severe forms of mental illnesses. And again, this definition of serious mental illness as well, that it results in serious functional impairment, and that substantially interferes with or limits one or more major life activities. And many of those individuals will probably be considered disabled. And this is where mental illness is really a very strange disease. It is a disease in some fashion. Those of you who specialize in brain chemistry or neuropsychology, you might already know a lot of underlying biological causes for mental illness. We know for a fact now that most of the schizophrenia symptoms really are results of serious neuroleptor malfunctioning in your brain. Some of the other illnesses, major mental illnesses such as depression, we are learning more. Sure, we are learning about the functioning of the same neuroleptors, serotonin and whichever you name, you can see they may have some impact. But at the same time, this is why psychology is so interesting to all of us, is really at the same time your environment, your other life experiences, they can also create mental illness. They can actually create biological basis, and the burden of this mental illness is really especially borne by the seriously mentally ill individuals who might be considered disabled from time to time. It's not as visible, sometimes it is visible. When it's visible, we often see the visible aspects of mental illness in perhaps certain kind of really explicit presenting behaviors that most of us will probably agree is not normal. As I said, I grew up in Calcutta, and I had a neighbor family. They had 7 brothers. 5 of them were seriously mentally ill. And one of them, who actually went around the streets, didn't do any work, and he actually was quite an accomplished individual. He actually played for a first division cricket team in Calcutta. But at the age of 23 or 24, I suspect, now knowing what I know, at that time I was very young, so I couldn't quite tell, knowing what I know, he probably had a late break of schizophrenia. And he really suffered. There was no treatment. And also all his brothers, 4 of his brothers had various problems, and they actually were most of the times locked up in their house by their 2 remaining brothers who were, again, quote unquote, normal. They had a much more difficult life. We could hear them from our house, 4 of them. Some of them would be shouting, some of them would be asking for food, and we could hear every word. But this particular individual, he would be going around, he was sitting around, and sometimes he would show up and knock on your door. And one time I opened the door, and the thing that I noticed, I was very young, I noticed that, oh, he's walking around. His shirt collars, it's full of bed bugs. In Bengali, we call it charpoka. He had no care for that kind of thing. And we will probably consider that a disabling condition in today's definitions. This is where one of the things I should have mentioned before, why presenting to a university in India, I hate to talk a lot about the United States because there's often a much better societal or family integration and acceptance of illnesses that simply does not exist in the West. So yes, the West has a lot of techniques, a lot of different knowledge that comes from the West in terms of biological basis and whatnot, but in social environmental practice with mental illness, a country like India probably has a lot to teach other countries as well. I'm not going to say that these 5 brothers had the best quality of life, but they were integrated in the family and in the community in some fashion. But I would, with my knowledge and training today, I will probably consider them seriously mentally ill with significant disability. So that's the good definition that American Psychiatric Association has, but really for practical purposes, and again, in the Western world at least, practical purpose is all what is known as bottom line dollar. Where is the money for treatment going to come from? And that's the insurance and reimbursement piece. And insurances, and now I know in India from my friends I hear, you also probably have some kind of health insurance, and they cover certain kind of illnesses, certain kind of incidents, certain kind of health or mental health services, and some others, they might be part of it. And in the West, it is really driven, especially in the United States of all the Western countries, it is really driven by insurance. Who is going to pay for your mental illness treatment? And that, for that practical purpose, really, the definition is very, very based, very significantly based on diagnosis and also severity of that diagnosis. Those of you who work with DSM-4 or 5 or ICD-10 type of disease classification, you already know very well many of the illnesses, such as major depressive disorders, they have different types of severity levels, or PTSD, or in general, some certain types of psychosis as well. So you just having a diagnosis is not necessarily reimbursable, or you wouldn't be considered disabled. You have to have the accompanying severity of symptoms. what is also known as medical necessity for treatment. In short, we often call it in this country as medical necessity criteria. So if you don't meet the medical necessity criteria, you will probably be diverted to treatment system for the mild to moderate or M2M population treatment. And that medical necessity is really a combination of your diagnosis and symptom severity. Burden of SMI. It's really, it can pose tremendous burden on an individual. And what I didn't write here is really not just the individual, it's the individual, the family, both. There can be tremendous life burdens. And oftentimes they will show up as failed relationships, social isolation, serious financial struggles, or inability to hold a job, or finishing college or school. There could be other severe symptoms that are co-occurring disorders, such as, physical illnesses. A lot of seriously mentally ill individuals are smokers. They might have lung disease, COPD, or substance use disorders. That's very common for a certain segment of the mentally ill. Those of you who work with PTSD, a lot of the times, substance use disorders is really a manifestation of an underlying trauma. In fact, a lot of our treatment system has now evolved to trauma-informed care system. Even some of the evidence-based treatments, such as cognitive behavioral therapy, the new word is TFCBT, trauma-focused cognitive behavioral therapy. So that's a very common co-occurring disorder with mental illness. Often we think of mentally ill, and this is probably more true in the Western world. I really cannot speak to the Indian context anymore. But in the West, there's a misperception that mentally ill individuals are violent, because they may have seen somebody walking around making odd gestures or kind of acting a little violent, but not really actually touching you even, but might threaten you or something. That's the general perception, but in reality, seriously mentally ill individuals are more likely to be victims of violence than actually being perpetrators. Also, maybe perhaps the other thing to say is not just victims of violence, they're also more prone to do some kind of self-harm. I'm sorry, you know what? I actually realized I didn't get to the next slide on this computer. So the other bullet, which is not here really, is the self-harm. And suicide really falls in that category, or suicide attempts. So that's another huge impact of mental illness associated with certain kind of symptoms. I wouldn't spend time on this. I just want to include this slide. It's actually taken from Wikipedia, nice graphic, but this is something more and more those who work in mental health, or those who work in public health even, we're learning more and more that we are losing anywhere from 20 to 25 years of life expectancy because of serious mental illness. Serious mental illness can take various forms, and one of the things is we talked about the co-occurring disorders. So if you have other physical illnesses, and actually seriously mentally ill individuals are more prone to have some serious physical illnesses, but more importantly, they will often not seek care for their serious physical illnesses. And that's where loss of life comes in much sooner. So in other words, maybe if your country's average life expectancy is 80 years, a seriously mentally ill individual is probably more likely to die by the age of 60 or 65. And that's a really sad thing. And during the time they will live, they will also have, and this is the daily thing, disability adjusted life years. It includes quality of life. You might have significantly compromised quality of life while you're alive. Before I dive into community mental health, I would like to take a quick break and see if I can answer 3 or 4 questions before moving on to community mental health.
So there are 2 questions only so far. We can take them. Priyanka, can you read out the questions to sir?
Yes, sure, ma'am. Thank you, sir, for the lovely talk thus far. So I have 2 questions. The first one is, how can mental illness sometimes be happy?
Okay. And that's a really important and very interesting question. It's an intriguing question. Remember, I said mental health, just defining mental health. There could be a lot of different philosophical and theoretical differences in how we define mental health. And those of you who study perhaps the history of psychiatry and history of psychology will recall that, you know, the humanistic and existential psychologists really did not believe in mental illness, especially the existential psychologists. A lot of them, despite their own life experience during the Second World War in Europe, in France, in Austria, all these places, obviously there were tremendous trauma and tremendous different types of things, but existential psychiatrists and psychologists really did not acknowledge mental illness. And one of the things was, it's really a matter of, you know, in psychology, we often talk about norms, and norms are only norms. Norms are very statistically based. So when we set the norms, we kind of define what is happiness and what is not happiness. And that is from our own perspective, whether it's professional or whether it's our own personal belief. But really, there is no real way, even in today's psychology, to get into somebody else's mind and not, or somehow to say blanketly that this individual is not happy. But I will add something else. Happiness, you know, this is interesting because I missed the other ones, all the other talks on this series so far, because they're at a very early time in my, with my time. You know, it starts at 6:30 my time in the morning. I'm not, you know, I'm barely out of my bed at that time. But I did make a point just to attend at least one, just to see how things go. And I attended Dr. Chatterjee's presentation on mindfulness and Buddhist philosophy and how that manifests itself and how that really works. There is no either or. That's the point I'm trying to get at, that between mental illness and happiness. Happiness is in some ways a subjective state of being, and you can be happy despite other people calling you mentally ill. I will not make it, if I were to draw a Venn diagram, I will not make the 2 items really completely 2 different sets. They will have intersection. You can be mentally ill and you can be happy.
Thank you, sir. I'll go to the next question. depression can be a symptom as well as a disorder. Please say something about this.
Right, and that's really a basic question of, diagnosis. When we diagnose somebody, those of you who are clinical psychologists or psychiatrists, at least in the United States, really, these are the two professionals who can actually officially diagnose. Other people can help, social workers or mental health technicians or nurses, they can help in diagnosing and note down the symptoms and severity kind of things, but really to actually put the label on, you have to be a clinical psychologist or a psychiatrist. So that's the big thing we do, and this is not just for depression really, it's for almost any diagnosis. There's the symptoms and severity that we look at in identifying or making a diagnosis, and that's what it is. So depression is a disorder, and it may have certain neurochemistry, brain chemistry that may manifest itself as that, or else sometimes it's the impact of certain trauma in your life or certain concurrent events in your life. And that's the state of depression. That's the, disorder is a very hard word, but yes, it is a disorder in some ways. But really, the symptoms is the way we get to define the disease often. Okay.
Okay, so
All right.
no, so we do have more questions. Can we take 5 questions, or should I keep them for the later part?
Yeah, let's do that. We might have to shorten the last half hour to maybe 20 minutes. That's fine, but let's answer a couple more questions now.
Okay, I'll continue that. Okay. So the next question is, in this pandemic situation, what will we do for a better mental health condition?
I was going to include some slides on that because that's what we are dealing with here as well. With all these lockdowns and things that are happening, people moving to telehealth type of situation through telephone or Zoom calls, doing therapy. And one of the things, because in my work, I speak with clinicians and their supervisors and actual individuals who receive services. I speak with a lot of folks. And one of the things I'm hearing in the last 6 months is really how difficult it is to create a therapeutic alliance with the individual, with your patient or client. It's a really difficult situation, and it is really exacerbated by the fact that pandemic is really causing certain types of social isolation that none of us have experienced before. Earlier, I was talking about, coping skills. A lot of us, kind of naturally navigate that kind of hard water. But for a lot of individuals, that's a traumatic experience. A little bit of social life they may have developed as a result of treatment that can go really, that can become difficult. Or maybe seeing the therapist once a week was a highlight of somebody's life, and that's been taken away to a video call. Not being able to see their relatives or loved ones, all these things, when you have serious mental illness, the impact can be really much, much more severe. So one of the things though, there's no, we're just going through it. So we don't have a magic bullet. We don't have an evidence-based treatment that has been tried in various settings to say, hey, cognitive behavioral therapy, that works with a lot of these folks. Yes, but we just don't have a modality to deliver that service. It's a very tough question, whoever asked it. I will say it's a very, very tough question, and what I'm finding is a lot of therapists and psychiatrists, they're really coming up with their own ways of dealing with it. That's not always the optimal, and there is no real clear answer to this. But certainly it's both a cause for further mental stress and illnesses, as well as making the existing mental illness worse because of certain setup suddenly disappearing from around you.
Okay, so one more question. Why is it hard to accept mental illness? Is it due to the lack of awareness? And if so, how can we spread awareness?
It's a difficult question. You know, I will get to this one toward the end of the presentation. I would like to spend some time on stigma and acceptance if we have time. But very briefly, you know, what we find is awareness doesn't happen overnight. It's really a process. And understanding mental illness for all common individuals, I think the audience here, probably most of you have certain kind of levels of expertise or knowledge in psychology, and a lot of folks don't. And we are really talking about the general public. We're not talking about the professional psychologists, psychiatrists, social workers, nurses. We're talking about the other folks and how they deal with it and what is the best way to bring about that kind of awareness. You know, one of the areas that I'll get to a little later and I want to talk about is really talking about advocacy, the family members, the folks you know. Any awareness is really only fruitful if you actually experience in life. You can stop somebody on the street and start saying, sir, I'm going to tell you a little bit about serious mental illness. That person might listen to you and might be polite to you. That person may not become aware until you can actually make it relatable to that individual and start with the conversation perhaps. Do you know someone who might be doing certain kind of things like this? Or might be suffering from certain kind of things like this. What do you think of that individual? That takes a lot more one-on-one conversation. That's very tough, but that's the way you can really develop real awareness. Mass awareness, media, those things have certain impacts, and you know, there's a lot of evaluation literature on media impact. That's not as solid. So I'll get to the stigma part a little bit because that's one of the barriers to seeking mental health treatment.
Thank you, sir. We'll take the rest of the questions towards the end.
Okay, all right, great. So community mental health. And this is, again, I'm speaking more from the experience in the United States, and it's really involves the population that becomes disabled as a result of the severity and chronicity of their serious mental illness. And in the Western world, I'll go a little faster because there's not really a whole lot of things, and you will get the presentation. But in the Western world, generally it's mostly because these individuals are considered disabled. Disabled individuals are normally treated with public funding. Even in the United States, where insurance system is so pervasive, if you have any disability that's accepted, your insurance comes through public funding. In this country, it's known as Medicaid. Medicaid is specifically for disabled individuals, and that definition of disability also extends to the individuals suffering from serious mental illness. So that's kind of the way community mental health is funded and delivered in this country. There is a history of uh, community mental health. And this is the Community Mental Health Act of 1963. This was signed into law by President Kennedy. And that led to establishment of some community mental health centers. And the main focus was really to get people out of institutions or acute care facilities. And again, you know, people may have their own frustrations in their own countries and their own settings. And it is no different, I can guarantee you, in the United States. This particular transition wasn't smooth by any means. It really went through a lot of road bumps, roadblocks, and at some point, when Ronald Reagan became the president, and that's when I actually came to this country, I saw the impact of that when he converted most of the funding for disability that's provided through Medicaid, converted that to what is known as block grant. So the state started getting some money and they could do whatever they liked with it. And really the state of care became very different from state to state. So there were lots of different challenges with that. And the community mental health centers were not built uniformly across states. And as a result, one of the things you will often hear, and those of you who have traveled to this country, sometimes you might really wonder, why is such a rich country, why are there so many homeless individuals in every city? Or most of the big cities that you know of, New York City or San Francisco, where I was working, Los Angeles, a lot of these cities, there's a lot of homeless population, and a sizable section of them really have serious mental illness who were released, or they don't have any particular long-term care facility anymore, and they don't have the right support. So it's not been necessarily the smoothest transition as much as folks would have liked. There's always room for improvement in this. One of the slides that I did not include here, and I'll speak about that here in the slide set you get, I'll include that slide, is really the types of community mental health, because types of community mental health really tells you what community mental health is all about. I think the most driving force behind community mental health, if nothing else you learn from this lecture, is what I'm going to say, is trying to keep an individual with serious mental illness away from institutional care. Whatever it takes. It may mean sometimes you will be spending one full day in crisis stabilization, which is very severe type of service. But if that keeps you away from institutional or acute care, long-term hospital care, then that's still considered in this country as community mental health. But frankly, most people, when we talk about community mental health, what they understand really is outpatient or one-on-one care, group therapy, all those kind of things. Here it's known as specialty mental health services, and they're mostly concentrated around case management, outpatient, and other specialty mental health services that are not necessarily at that level of like crisis stabilization. But there are outpatient crisis intervention programs in the States in most cities and places. So the focus there is, okay, somebody maybe, just as an example, maybe somebody missed a couple of doses, somebody's on atypical antipsychotic, maybe missed a couple of doses and is acting up. All he or she needs, maybe the medication, that he or she takes the medication. that's a crisis intervention. You know, you don't really need to go to the hospital. As long as you reach a professional who knows what's wrong and actually addresses that problem right then and there, that's a diversion. That's a diversion from acute care. So community mental health, really the focus is to keep you away from institutional or long-term acute care by any means, even if those means can themselves be sometimes fairly intensive care. Another term, and I don't know in India, and I hope some of you might educate me someday, is really intensive case management. Intensive case management is very common in this country, and that's generally targeted for fairly symptomatic and individuals with serious functional impairment, because that's the way where the individual will have access to their case manager and therapist 24/7, anytime during the day, any day of the week, they will have access to their therapist. Or if the therapist is off, at least somebody who will be familiar with that individual's situation. So that's the way to keep people out. So that's community mental health, and I'll include this slide in the presentation that I sent to Shaili. Quality in community mental health care. This is really my field. What does quality really mean? And just like what is mental health, what is mental illness, there are also many, many ways to define quality of care. But generally speaking, quality of care really revolves around these three concepts of structure, process, and outcomes. And Institute of Medicine in the United States is a big think tank kind of an institution that talks a lot about healthcare in general, and quality is not just for mental health. Mental health quality really borrows a lot of their concepts from healthcare quality. And in healthcare quality, really the bullets I've included here: patient safety, care effectiveness, patient-centeredness, where the patient actually have a voice. Your treatment is patient-centered, and that's in mental health. Treatment plan should really take into account what the person you're treating is telling you. It's not what you're planning to treat necessarily. You have to take that into account. Timeliness of services and care efficiency and equity. And equity is a big thing in this country, really, and I'll get to it in a second, a little bit more maybe. As my bio said, you know, I was the ED of the External Quality Review Organization for California, and we really focus on these 4 areas in assessing quality. One of them is quality of care, but really there are 3 other very important aspects to quality: is access to care, timeliness of care, and outcomes. And one thing to keep in mind, quality is not really a one-time activity. It's continuous. Many of you might have heard the term CQI, continuous quality improvement. That's a big buzzword, but really quality is, somebody said once, you know, I can't remember who said that, but it's just in my head, that quality is doing the right thing when no one is looking. It's very easy when somebody is keeping an eye on you to do the right thing, but you know, when nobody's looking, are you still doing the right thing? That's your quality, ensuring quality effort. You know, I'm sorry, I did not, this is the slide I was talking from. I'm really sorry about that. Anyway, I'll move on to the next one. Those 4 areas, just briefly: access. How do we ensure access? We look into all these things. That a mental health plan actually has all their service information easily available, that can be accessed. Maybe it's on the website, maybe it's flyers, maybe it's brochures, maybe they're advertising on the radio or television. We look into all those kind of things, because without the information being available, there is no care. Even after people know there is service, where is that service located? Is that easily accessible? That's a big thing. Once you get to that door, does that building have sufficient capacity? Do you have enough therapists? Do you have enough doctors? Do you have enough nurses? Whatever kind of specialty you need. Are there those kind of folks? Are they addressing your cultural issues? And this question came up, stigma. Once you're knocking on the door, is the clinic or the location have things in place that are trying to reduce stigma of mental illness? Is it a welcoming place? Where you come in, you're treated as an individual. You're not treated as somebody, a patient, a mentally ill individual. You're treated as an individual first. And you're educated about what to expect, how your treatment proceeds, those kind of things. Those are all access-related information. Timeliness. Whenever I think of timeliness, I often think of really motivational interviewing. I don't know how many of you actually practice motivational interviewing, and that's started with substance use disorder treatment. But a couple of the initial stages of motivational interviewing is really pre-contemplation and contemplation. These are very crucial times when an individual might be seeking treatment, and that applies to seriously mentally ill individuals as well, or their family members. They can change their mind. They're knocking on your door looking for service, and they're waiting. It's very easy to give up because they just had gathered up enough contemplation or courage to seek that service. If you're not providing that in a timely manner, you're losing a big opportunity to deliver that treatment. How long does it take to see a psychiatrist, get a med assessment, those kind of things? How long does it take to get urgent or crisis care? If you were hospitalized for psychiatric reasons, how long does it take for you to get care after you're released? That's a very vulnerable time. Those of you who actually worked in inpatient psychiatry units or acute care psychiatry units, you know people come out with a lot of medications often, and they're very vulnerable. All their symptoms haven't been stabilized yet. They need a lot of hand-holding, and that time of follow-up is a very important thing. Are they going back to the hospital again? That's a treatment failure. How do you reduce no-shows? People make an appointment, don't show up because they've changed their mind. How do you actually, again, motivate them to keep on seeking treatment? Quality. And quality of care is really the degree to which health service, and this applies to mental health as well, that you increase the likelihood of your desired outcome. So in your treatment plans, again, those of you who, probably all of you, have some training in creating a treatment plan. In your treatment plan, you might be having certain goals, such as such and such will go out to grocery shopping twice a week. How do you actually ensure that's the outcome you're going to get? You might be using certain types of therapeutic or intervention techniques that are current with your professional knowledge. And in fact, most of the other sessions on this series, I noticed, are really consistent with increasing your skills and knowledge in very specialty areas of treatment. So that's quality. when you are actually doing things consistent with your current professional knowledge? Are you providing the appropriate care? Somebody really needs intensive case management. You're only asking that individual to go to a wellness center and talk to their peers. May not work. That's not appropriate service. How are you engaging them? That's a big part of quality. Developing a therapeutic alliance with individuals. How are you monitoring their service utilization? How often are they coming? Are they keeping all their appointments? About your own practice, are you using evidence-based treatments, or are you just going by guesswork? Going by guesswork is not a trained psychologist's job. A trained psychologist's job is to actually follow, again, the current professional knowledge, and evidence-based treatments are the current professional knowledge. How well are you communicating with your client and exchanging information with other professionals as well as with the clients? Very important aspects of quality. This is my favorite bullet in outcomes. As we move to outcomes, when I first took a job as a research psychologist in San Francisco, the first time I walked into my boss's office, behind him, he had a huge poster that said, "No outcome, no income." And that was really addressed toward the treatment provider. If you really cannot show outcomes, you don't deserve to earn money out of that treatment. There are many, many types of both process and outcome indicators that you can be using in order to assess your success, your treatment success. And a lot of this measurement has to be also informed by your client. They should also tell you that they are improving, but just them telling you, oftentimes this is a huge thing in mental health treatment, in satisfaction surveys and stuff. We often see folks are really happy with their therapists, yet in terms of their improvement in functional or reduction in, not much. Even they will say that. And then there are lots of outcomes that are often associated with a particular evidence-based treatment that you might be using. That might be, I listed quite a few. Some of them are really for children's side. Children's side in general have more evidence-based treatments, like, PCT, which is parent-child therapy, and then MDFT, that's multidimensional family therapy. So there's a lot of them. DBT obviously is the dialectical behavioral therapy. So there's a lot of different ones that are for adults, but more often you will find evidence-based treatment for children. Those have been tested more extensively, at least in this country. I know I'm kind of running a little short of time. These are the additional areas that are also kind of part of the broad umbrella of quality. One huge thing that we look into, and that is federally mandated in this country, we assess every organization's information systems capabilities. Why? Because paper charts do not work. They do not allow seamless communication. And really, India is at the forefront of information technology revolution. So I'm probably not, my knowledge is probably much less than yours in this field. But what I know is electronic health records have really revolutionized care. And we look into that, what kind of electronic health record an organization may have, how well that functions. Cultural competence. Again, this is another very specific to the United States, obviously, and there was one lecture I noticed, the first one was on cultural issues in this series. That's a big issue we look into as well, that those who are providing services, because this country has so much diversity, that they're able to understand culture. That's one thing about mental health. And again, happiness. Mental illness has a lot of cultural denominations. The whole concept, the construct of mental illness is so dependent on culture. So unless you really are addressing your client's culture, you are not going to be able to really be a very effective treatment provider. And the very important one, whether you have a wellness and recovery focus, the best job you can do is when you become actually without work, because your client has graduated, has recovered, is doing well. That's when you know you have done a really good job. What's the culture of the organization? Places where there are multi specialty folks working together. What is the culture there? How are they communicating? Training, expertise. You know, it's easy to talk about your, consistent with your professional knowledge. But if the organization you work for is not providing you with continuing education, providing you the right type of exposure to those kind of trainings and current knowledge, then you are not going to be able to be current in your knowledge. What kind of array of services that are available in that system of care? Do you have all types of things that's available? I know I went through the last part rather quickly, but I do want to share, in United States this weekend is Martin Luther King birthday. I just want to leave some parting thoughts in this last slide. And that's, for the mentally ill individuals, there's a lot of injustice in our society. And injustice anywhere is a threat to justice everywhere. And this is my advocacy about mental illness. And, never think that, oh, I'm too late to do the right thing, or this is too early to do the right thing. No, the time is always right to do the right thing. With that, I will take some questions and comments if there are, or if people just even have comments. I don't mind hearing those.
Sure, sir. Priyanka?
Yes, sir. I'll start with the questions. What are the basic differences in the perception of mental illness here and in the West?
Yes, that's the question I'm probably not the best equipped to answer. I wish somebody like Dr. Chatterjee, who has both experience in India and United States and England, would probably be in a better place, or the first speaker, Tusharika, who also works in both settings. Because I really have not worked in mental health field in India. One thing I will say, just because I grew up there and I was talking about my neighbors, that house full of brothers who were seriously mentally ill, is just our acceptance of mental illness. That's a very different type of illness. A long time ago, I studied in Japan, studying their system for mental retardation, what kind of system of care they have for mentally retarded individuals. And in one of the first lectures, the Japanese professor said a very interesting thing about the West and Japan, and I'm putting India in the Japanese class because that's Asia, and Asian culture have a lot of commonalities than, with the West. He said, for the mentally retarded in United States, that's where this professor, by the way, was trained. He said, in the United States, the institutions were built to protect the society from the mentally retarded. In Japan, the institutions were built to protect the mentally retarded from the society. And I think that's a very important insight that I learned from that individual. I was much younger, and it has never left me. That's what I would say.
Okay. Next question is, what is the difference in role of a clinical psychologist and a therapist in the US?
That's actually not particularly different from India in a lot of ways, believe it or not. And it really depends on what type of practice you're doing. You know, in fact, this particular topic, today's topic, community mental health care, in the United States, by and large, clinical psychologists do not work in this field very much anymore. Used to be a time when I first started working as a research psychologist, you know, there were a lot of clinical psychologists who worked in community mental health system. But clinical psychologists, by and large, have moved on to a different type of practice. And often that's private practice, often that's working in different types of areas of clinical psychology, such as school psychology, or, you know, working in organizational behavior type of areas, partly because social worker, and there's a couple of other classifications. One is marriage and family therapists. These are master's level therapists. Their scope of practice has expanded a lot, and their salaries are a little less. So why would a system pay a clinical psychologist a PhD? Because in this country, I don't know about India really, but in this country, to be a clinical psychologist, you have to have a PhD in clinical psychology, and you have to obviously finish all the clinical hours in order to be certified. But their salaries are higher. Why would anybody pay that? So clinical psychologists is kind of like a mutual divorce that's we have been going through. That clinical psychologists have moved on from the community mental health system.
Okay. I have a question from somebody who has stayed in the United States for 5 years, but somehow couldn't get hold of a proper mental health provider. He's saying that a small necessary medical attention goes through a long, intensive process. And why is this so? Is there any small institution to get hold of it that he missed? Is mental health institution more accessible in community level in India compared to the United States?
You know, again, I cannot speak to the Indian one. I heard a little bit in talking to Shirley before this, in planning for this presentation. But in the United States, I'm really sorry that's what happened to this person. And one of the biggest shortcomings, one of the things I talked about, that the transition to community mental health care was rocky. You know, not every state. So first of all, it really depends on which state this individual was. That's a big thing. Not all states are similar in what they will cover, what they will provide, and how many services are available. But the second thing is really, again, going back to the insurance part of it. So to the extent your mental illness moves from that whole universe of AMI, any mental illness, to a serious mental illness, and you are qualified as a disabled individual, then your care system is pretty good. But if you haven't reached that threshold, it's a very broken system. That mild to moderate care is typically assigned to the regular insurance companies in this country known as managed care plans. And they really do not do very well with individuals who are kind of bordering between moderate to serious mental illness. They don't do very well. And there's a lot of issues. You know, I can give a huge lecture just on that topic. It's a topic very much to my heart. And I'm always frustrated by what happens to these individuals. The other question of, is there a small place or small practice or institution? You know, there's a lot of them. Those are all private pay. So, you know, most of you know United States through Hollywood films. and all those Hollywood celebrities, many of them have mental illness. Where do they receive treatment? They go to private settings. If you have enough money, you can get any treatment you want in this country. Just like India too. I'm sure in India is the same case. If you can privately pay, you can probably get the best care. And that's a big problem because often, there are individuals who are suffering from certain symptoms, yet they cannot really afford that kind of private level of treatment. So there's a big crack right there between the two systems.
Yes. Okay, so next question is, how does one deal with someone extremely egotistical who withdraws if anything goes against his opinion? He can't communicate freely with family members.
Yeah, I'm not going to give advice on a particular individual situation because that is really a therapeutic technique kind of thing. And depending on who is asking the question and what is his or her skill in delivering that particular treatment, that's going to be very specialized treatment. But what I would say, just as a systems person, if you haven't been able to handle it yourself so far, if it's possible, seek professional help. What happens, I briefly mentioned borderline personality disorder. That's a really difficult thing because that's the kind of individuals, if you're in a therapeutic situation, the countertransference is really high. How do you handle those kind of situations? That's why dialectical behavioral therapy is really a great tool. I'm not trained in dialectical behavioral therapy. I'm not going to talk about it. I mean, I know the basics, but I'm not really trained in it. So that's why I'm saying that you have to go to a professional who can actually or has experience dealing with that particular type of personality disorder.
Okay, so next question is, as it was mentioned, most of the time mentally ill persons are the victim rather than the perpetrators. But aren't those who are bullying or being threatful intimidating to others suffering from something more dreadful?
Yes, again, that's the whole class of personality disorder. And many of them, they fall in different categories, as you know. But the personality disorder folks can range in such severity and, bullying practice and those kind of things. They have certain kind of personality disorder. And almost in any serious mental illness, if that really became a serious mental illness level thing, until you actually develop insight into yourself, you're never going to really recover from your mental illness. Likewise for bullying, those are bullies. Yes, sometimes you may be able to, understand. I mean, not everybody is born as Ashoka. Ashoka had a revelation after the Kalinga War, right? A bully may not have that revelation without some professional help. And even with professional help, I'm again saying that in a lot of ways, as severe as schizophrenia or bipolar disorders may be, they are much, much more responsive to medication and other psychotherapy treatments. Not so for personality disorder individuals. It's a very special class of problem. We deal with it. They don't qualify for specialty mental health services often, and their relatives are driven nuts. You don't know what to do. If you can find a professional, that's probably the best way.
Okay, thank you. Next question is, can you elaborate on disability being caused due to SMI?
Yes, and that disability is really, again, if you look at the functional or symptomatic impairment. So let's just take the example of somebody on a wheelchair, because maybe the lower part of the body has become paralyzed for some reason. I don't think any of us will disagree that individual is disabled. Now, that person is disabled because of certain functional manifestation. Maybe he or she cannot walk without the wheelchair, cannot move around, okay? Likewise, for mental illness, you have to think of that in terms of your functional impairment, behavioral impairment, symptoms manifestation. That's the only way to think about disability for mentally ill individuals, because then you will find, yes, this person is disabled because he or she cannot go to work, cannot hold down a job. Different kind, but it's a disability.
Okay, so thank you. Next question is, third world and developing countries do not have a lot of mental health awareness. How can one spread awareness to the masses? What methodology should be adopted to spread the awareness?
Yeah, and you know, this is a serious question. And again, I'll say that I haven't worked in India, but really this is where I would really encourage people to look up literature that are generated by World Health Organization. They actually use an instrument, and even a country like United States, I'm finding more and more clinics are using that, called HODAS. I can't remember what that stands for, but that's essentially I don't know how many of you know of PHQ-9, which is another screening tool. So there's a lot of ways you can actually screen individuals, and that's one way to spread awareness. The question you have to ask yourself, if you're really working in India and you're working in the community, is to what extent you really want to create a label for an individual. If that individual is well integrated in the society, in whatever fashion, it may be a question of improving that person's functionality. So that's fine, but you know, it's better not to put a label unless it is absolutely necessary and unless you know for a fact that you can provide the right kind of treatment. To the extent you cannot do that, then your next best thing to do is really to provide very concrete steps toward improving functionalities or functioning.
And last question, sir. People put hunger, job security of their families in priority over this pandemic disease. Can you please explain? We have also seen the examples of migrant workers.
Can you repeat the question one more time, please? Sorry.
Yes. People put hunger, job security of their families in priority over this pandemic disease. Could you please explain? We have also seen the examples of migrant workers.
Yeah, and this is again, it's happening in this country as well, as you can see. I mean, it almost seems like this person is speaking from United States, because one of the big battle in this country really has been, you know, for instance, wearing a mask. It's been a big issue, right? And a lot of people are talking about this personal freedom. Likewise, a lot of businesses, they don't want to close down just because the government is asking them to close down. We know from a public health or how viruses spread, you know, we know how those things happen. That does not really mean, even in a country like the United States, individuals or businesses are going to prioritize the pandemic over their own livelihood or keeping their business open. It's a really tough situation. And from my friends in India, I mean, what I hear, people are going about their life, you know, doing a lot of things. Kolkata has pretty much opened up a lot. But it's, I really don't have a good answer to this question, but it is a big issue, I will say, in the United States right now.
Thank you so much. So that's all. Thank you.
Thank you, sir, for presenting such a wonderful lecture. It was quite elaborate. Before ending, I would again request Professor Rita Basu to deliver a vote of thanks.
Thank you, Shahili. It is my privilege to propose the formal vote of thanks for this webinar. At the outset, on behalf of our department, I would like to express my profound gratitude to the speaker and my friend, Dr. Saumitra SenGupta, for sparing his valuable time to address the gathering. He enlightened us with the successful treatment, recovery, and care system in USA with scope to adapt universally. His talk focused on serious mental illness. He pointed out the medical necessity criteria are the diagnosis, treatment, and insurance, where quality indicators, safety, effective careness, patient-centeredness, timeliness, care efficiency, care and equity, with a target to make the productive production in activities, make them productive in activities, healthy in relationship, and ability to adapt and cope with the adversity. Thank you once again, Saumitra. We are indeed grateful for the presence of all participants. Sincere thanks to our head of the department, Professor Subrata Dasgupta, for organizing such a program. And also my sincere thanks to organizing committee members consisting with the faculties and the supporting students members for making this program a successful. Thank you, Saumitra. Thank you once again.
Yes, thank you. Thank you very much. And thank you for organizing. I mean, I'm very impressed with the whole series of lectures that you've organized. It's fantastic.
This is a reminder to all the participants that please fill in the feedback forms before you leave. The link will be open for 10 more minutes.
Can we leave?
Yes, you can leave after you have filled in the feedback form. Thank you.
Yeah, I'm done with the form. Thank you.
Okay, I can sign off, right, Shirley?
Yes, sir.
Okay, thank you,
sir.
everyone.
Thank you,
Thank
sir.
you for joining today. Thank you very much.
To all the other participants, you may leave after you have successfully filled the feedback form. Thank you.
Excuse me. Actually, I have a question for the moderators.
Yes, please go ahead.
Yeah, so I just wanted to ask, the series of webinars are actually held in a very beautiful way, but can we just have the PPT presentations that you are showing to us on the respective emails that we are sharing through the form, if that is possible?
We can share the PPT only if the speaker agrees with it because it is their own making. And in case the speaker agrees, then we can try to send it via email.
Yeah, sure, definitely. Even today's and the before webinars as well. So if the speaker agrees, can you please send us on the individual emails, because I saw many messages in which they were saying that they wanted a PPT so for future references, and they were very nicely prepared. So it can help us in our journey.
Yeah, we shall try doing that.
Okay, thank you so much.
Shirley, we are about to end the meeting.
Yes.